Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee of the second annual Congress of the Arab Thyroid Association for inviting me in this important topic. Today we will share the session of the pregnancy track. We have three important topics, and my co-chair is Dr. Ghada Al-Khatib, who is a professor of diabetes and endocrinology. She in Asyut University. She's the president of Egyptian Thyroid Association, as well as the head of scientific committee of Arab Thyroid Association. Dr. Ghada Al-Khatib will present the three coming speakers of this pregnancy track. So, تفضلي Dr. Ghada.
Good afternoon, everyone. First, welcome to you in the second annual Congress of Arab Thyroid Association. And it's my pleasure to share this session with Dr. Salwa Al-Aidaros, KSA. This track is pregnancy track, and we will start with Professor Elizabeth Spears, Professor of Medicine, Boston University, School of Medicine, Boston, USA. She will talk to topic management of TPO positive euthyroid with pregnancy, and the second topic will be how to manage TRAb positive pregnancy lady with Graves' disease.
Good afternoon. It's a great pleasure to be with you this afternoon. I'm going to discuss the management of TPO antibody positive euthyroid women in the pregnancy and preconception setting. And I will follow that by my second talk, which will be a discussion of the other flavor of thyroid antibodies in pregnancy. We'll talk about the TSH receptor stimulating antibodies at that time. So to start with, I want to walk through a little bit of the epidemiology and natural history of thyroid autoimmunity in the pregnancy setting. And then why it matters, what cohort studies demonstrate in terms of the obstetric effects of TPO antibody positivity in pregnancy. And then we'll review what we know about the three interventions that have been studied to date, which are glucocorticoids, selenium, and levothyroxine. So to start with, thyroid autoantibodies are fairly common in pregnant women. It's been estimated that anywhere between about 5 and 14% of women are TPO antibody positive in pregnancy. About 3 to 18% are thyroglobulin antibody positive. Important to note that most of the data that I'm going to discuss today really relates specifically to TPO antibodies, that we have far less information about the effects of thyroglobulin antibodies in the pregnancy setting. Risk factors for thyroid autoimmunity certainly include either a personal or family history of any other form of autoimmunity, older age, European ancestry, either too little or too much iodine in the diet, and specifically for TPO antibodies, iron deficiency is thought to be a risk factor. Now, the prevalence of thyroid autoimmunity in pregnancy really will depend a bit on when those antibody levels are tested. Danielle Glinauer showed decades ago that antibody titers tend to decline fairly steeply over the course of gestation. So if you measure thyroid TPO antibodies in the first trimester and then measure again at the time of delivery, on average, there will be about a 60% decline as pregnancy progresses. Those antibodies then tend to reemerge in the postpartum setting. And the TPO antibodies, thyroglobulin antibodies, they do cross the placenta from mother to fetus, but as far as we are aware, they do not have adverse effects on fetal thyroid function. Importantly, maternal TSH does not cross the placenta, maternal thyroid hormone does. Now, in thinking about thyroid function in pregnancy, always important to remember that it changes across the course of gestation. And typically one of the major drivers of change in maternal thyroid function in a normal pregnancy is going to be human chorionic gonadotrophin. So recall that HCG levels tend to rise in early pregnancy till a peak at about week 10 or 12 of gestation, and then they decline again. And the HCG stimulates the thyroidal TSH receptor, so that when HCG levels are high, that will tend to drive an increase in circulating thyroid hormone, and that increase in circulating thyroid hormone in turn will feed back at the pituitary and cause a mild decline in TSH. We have known that for a few decades. What has only been appreciated, I think, a bit more recently is the fact that that normal thyroidal response to HCG appears to be compromised in women who are TPO antibody positive. These are data from 2 cohort studies, which is why the figures are paired, led by Tim Korovar. And here they looked at those same associations I just showed you, the relationships between maternal thyroid function and maternal circulating HCG, but they did something novel, which was to stratify by the maternal thyroid antibody status. So on the left-hand side of each figure here, you can see what I just showed you. There's a very clearly linear positive association between maternal HCG levels and maternal free T4, and a clearly linear inverse association between maternal HCG levels and maternal TSH. But that's only in the TPO antibody negative women. On the right-hand sides of each figure, in the TPO antibody positive women, you can see that those normal relationships between thyroid function and HCG appear to be attenuated or lost altogether. And so we think what may happen in a normal pregnancy in antibody negative women in blue is that slight decline in TSH in the early first trimester and then subsequent recovery. But in the women who are antibody positive, we typically are not going to see that decline. If anything, we may see a slight increase in TSH during the course of gestation. And so effectively what this means is that the curve for TSH gets right shifted. You can see that in white here are the antibody positive women, in black are the negative women, and you can see that the values for TSH are shifted to the right in women who are TPO antibody positive. So current guidelines from the American Thyroid Association for thyroid and pregnancy were published in 2017. These are getting a little bit dated, and it's important to know that these guidelines are currently undergoing a process of revision. But what we said in 2017 was that if you know that a patient has thyroid antibodies, either TPO or thyroglobulin antibodies, and you know that she's euthyroid, it's still important to follow the serum TSH in the first half of pregnancy when those HCG levels are rising and falling, when serum thyroxine binding globulin levels are rising, and when this is all very dynamic. Because we think those women who are antibody positive may have an underlying degree of compromise of their thyroid function and really may not be able to compensate for the increased demands of pregnancy. And if these antibody positive women have a TSH that rises to above 4 in the pregnancy setting, then levothyroxine would be recommended. Now, TPO antibody positivity doesn't just predict thyroid function in pregnancy, it's also a pretty strong predictor of thyroid function in the postpartum setting. So having positive TPO antibodies in the first trimester of pregnancy very strongly predicts the likelihood of a woman developing postpartum thyroiditis in the first year after she delivers. So what are the consequences of TPO positivity in women who remain euthyroid? And here we have really a growing body of evidence that TPO antibody positivity is associated with meta-analysis, with poor ART outcomes as seen in this meta-analysis. So here, women undergoing in vitro fertilization, if they were euthyroid but TPO antibody positive, were less likely to go on to have live birth than the women who were TPO antibody negative. So the odds ratio here is 0.73. We also know from decades now of research that women who are TPO antibody positive but euthyroid in early pregnancy have about a 2 to 3-fold increased risk for miscarriage compared to women who are antibody negative. More recently, we have this meta-analysis demonstrating that it's not just miscarriage, but also recurrent miscarriage, 2 or more miscarriages in the same patient, that seems to be linked to TPO antibody positivity with an odds ratio here, again, of about 2. And the other outcome that seems to be very consistently associated with TPO antibody positivity, even when women are euthyroid, is preterm delivery. So these are data from an individual participant level meta-analysis that was performed by a large thyroid and pregnancy consortium. I'm one of many, many members of this group. And in this analysis, which was published in JAMA in 2019, we pooled data from women in 19 different pregnancy cohorts. So we had 47,000 women in this data set. And what we saw here first is that there were no associations between maternal thyroglobulin antibody status and likelihood of preterm delivery. But TPO antibody positivity, again, even in women who were euthyroid, was associated with a significantly increased risk for both preterm delivery at less than 37 weeks gestation, but also for very preterm birth at less than 32 weeks gestation. And those very preterm births do tend to confer substantial morbidity. So we know this very clearly. This is consistent across study after study. What we don't know is the reasons why. So there are a few leading hypotheses for why TPO antibody positivity seems to be linked to these higher rates of pregnancy loss. One possibility is that women who are TPO antibody positive but euthyroid in early pregnancy, as I've shown you, may be destined without any intervention to go on to become hypothyroid as pregnancy progresses. And perhaps it's that development of hypothyroidism that winds up causing the pregnancy loss. But there's some other hypotheses as well. One is simply that this is not a true association, that this is confounding by age because both pregnancy loss and thyroid autoimmunity tend to increase as women get older. Although in studies like the consortium data I just showed you, adjusting for age really doesn't affect these results. It is possible that at least in some women, pregnancy loss is mediated by direct actions of thyroid antibodies. For example, some women who have TPO antibodies and have Hashimoto's also make TSH receptor blocking antibodies, and it's postulated that those might bind to and inhibit the HCG receptor on the corpus luteum, so cause early pregnancy loss. It's also possible that really the thyroid piece of this is non-essential, that the TPO antibodies are really just a marker for an autoimmune milieu, and that the pregnancy loss is mediated either by abnormal T cell function, so resulting in altered cytokines and altered inflammation, but not mediated by a thyroid effect per se, or also possible that having TPO antibodies is really just a marker for having other non-organ specific antibodies, things like anticardiolipin antibodies in the circulation. When we don't understand mechanisms, it's hard to know what the appropriate intervention should look like. But to date, there are 3 interventions that have been studied in randomized trials in women who are antibody positive but euthyroid. So the first of those that's been studied in 2 very small trials is glucocorticoids. And this has been studied in this trial in euthyroid TPO antibody positive women pre-conception. So these were women who underwent in vitro fertilization. 60 women were eligible for randomization if they were euthyroid, TSH here, less than 2.5, either TPO or thyroglobulin antibody positive. And they were randomized either to prednisolone, started at a dose of 5 milligrams a day at the time of oocyte retrieval and continued to the end of the first trimester, compared to no treatment. What you can see here in the blue bars, the prednisolone group had higher clinical pregnancy rates, non-significantly higher live birth rates, non-significantly lower rates of miscarriage. So a suggestion perhaps of benefit, but I would say really not definitive. And this is a very tiny trial with only 60 participants. The other trial we have for this is even smaller, an N of only 48. Again, this was an intervention in the preconception setting. So these women underwent intrauterine insemination. And here 48 TPO positive infertile women were randomized to prednisone, which was started at 10 milligrams a day and then tapered off over the 4 weeks before the IUI procedure, compared to women who got placebo. And here you can see that the clinical pregnancy rate in the blue bars, the treated women, was significantly higher than the women who got placebo. The miscarriage rate was not significantly different, although actually non-significantly higher. And again, we don't, I think, have definitive data. These are 2 very small trials, and larger trials would really need to be done. In the 2017 ATA guideline, we specifically recommended against glucocorticoid therapy for euthyroid TPO antibody positive women undergoing assisted reproductive technologies. That was partly because the trial data are so weak, and also because we do not really have a lot of evidence for safety profiles of glucocorticoid use, potentially in a very large number of antibody positive women, given the prevalence of these antibodies in the early pregnancy setting. So the recommendation currently really is to not use glucocorticoids, although perhaps there will be other trials down the road. The second intervention that has been looked at in randomized trials is selenium. And we know that outside the pregnancy setting, there are a number of trials, some of which have demonstrated that selenium supplementation may reduce TPO antibody titers, and some of which show no effect on thyroid autoimmunity. So it's a mixed bag outside pregnancy. It's also kind of a mixed bag in the pregnancy setting. The first trial to look at this was this one by Roberto Negro, done in Italy, published in 2007. And here they took women in the early pregnancy, around 12 weeks gestation, and they were randomized if they were TPO antibody positive in euthyroid to either 200 micrograms of selenium a day or to placebo. Those two groups were compared, and they also had a control group, which was TPO antibody negative, but matched by age. What they saw was that the selenium supplementation did significantly reduce the likelihood of having postpartum thyroiditis or just isolated hypothyroidism presenting in the 12 months post-delivery. And I should note that the selenium here was started in the first trimester and continued for 1 year postpartum. They saw a decrease in those TPO antibody titers in the selenium-treated women compared to the non-treated women, not really during gestation, but in the post-delivery setting. However, that somewhat positive trial was followed by this one. So this was performed in the UK. Here, again, women in early gestation, so week 12 of pregnancy, randomized to selenium here at a lower dose of 60 micrograms a day versus placebo. Here it was continued until delivery. You can see here the difference in the TPO antibody titers in both groups. Those antibody titers declined as pregnancy progressed, which is what we normally see across the course of gestation, regardless of treatment. But there was no significant difference in the TPO antibody titers within pregnancy in the treated versus the untreated women. And there was also no effect on the rates of thyroid dysfunction in the gestational setting. The third trial we have for selenium also comes from Italy. This was a multi-center Italian randomized clinical trial. Here the N is pretty small, only 45. Women were randomized at 10 weeks of gestation if they were TPO antibody positive in euthyroid. But a really important caveat in this trial is that most of these women were euthyroid because they were on levothyroxine already. They then watched both the thyroglobulin antibody titers and the TPO antibody titers in these women through the course of gestation, at the time of delivery, and then at 6 months postpartum. And what they saw was that there were lower antibody titers, particularly in the postpartum setting, in the women on selenium compared to placebo. Sorry, I said that wrong. In the gestational setting, the titers were lower, but really importantly, no differences in thyroid function. And they may possibly not have been set up to see those differences in thyroid function in this trial, since many of these women were on levothyroxine. So we have 3 trials, a couple showing potential benefit, one really not showing any effectiveness. And important to note, these are small trials. These were all conducted in either Italy or in England, both of which are parts of the world that historically have selenium deficient diets, which is not the case in other places, including in the US where I practice. It's also important to note here that selenium has multiple effects on the body. I believe there are 27 different selenoproteins. And so there is potential for off-target effects of selenium supplementation, and in fact, a signal in some of the selenium trials that it may increase risk for gestational diabetes. So with this data in mind, the ATA guidelines currently recommend against selenium supplementation for TPO antibody positive women, either in pregnancy or in the postpartum setting. So finally, we get to the intervention that has been studied to date the most. So that would be levothyroxine. And the first trial for levothyroxine in women who are TPO antibody positive but euthyroid is this one. This was conducted by Roberto Negro in Italy, published in 2006. And here they randomized women at about 11 to 12 weeks gestation if they were TPO positive and euthyroid, either to low-dose levothyroxine or to no therapy. They looked at miscarriage and preterm delivery, and they saw really remarkable risk reduction for both of these outcomes in the treated women compared to the controls, such that levels of miscarriage and preterm delivery were very similar to the women who were TPO antibody negative. So this trial engendered a lot of excitement, and there was a lot of interest in seeing whether these results were replicable in future studies. Unfortunately, we now have a number of trials in the literature that suggest that really that's not a replicable result. So the first of these trials I want to share with you is this one. This is from Faridun Azizi's group in Iran. And here they randomized women who were TPO positive who could have a TSH of up to 10. So these are a mix of women who are euthyroid and women who are subclinically hypothyroid. They were randomized to low-dose levothyroxine, actually using the same dosing strategy as the NEGRA trial I just showed you. And the primary outcome here was preterm delivery. You can see that there was a significant reduction in the preterm deliveries in the women who were treated with levothyroxine compared to the women who were untreated. And that translated then into a lower likelihood that these women's children would need neonatal intensive care unit admission. However, very important caveat here was that in sensitivity analyses, this benefit really only seemed to apply to women where the TSH was greater than 4 at baseline. So the truly euthyroid women in pregnancy in this study did not seem to have a benefit of levothyroxine therapy. We then have some trials that have recruited women in the preconception setting. So the first of these is POSTAL. This was done in China. They screened 32,000 women who all had a history of infertility and were going to undergo IVF. And they were eligible for randomization if they were euthyroid TPO positive. They randomized 600 of these women. 300 of them got levothyroxine, started at 25 to 50 micrograms a day, and titrated to keep the TSH less than 2.5. The treatment started preconception and was continued till delivery if there was a pregnancy. The controls were women who were untreated, and they looked at miscarriage rates, clinical pregnancy rates, live birth rates, and saw no differences between the treated and uncontrolled group, the treated and control groups. This was followed by Tablet. This was published in the New England Journal in 2019, conducted in the UK, and had a somewhat similar design. So here, 20,000 women with either a history of miscarriage or a history of infertility. And in this trial, some of the women wound up conceiving naturally, and some of the women conceived using IVF. They randomized 476 women to a treatment arm. These women got low-dose levothyroxine, 50 micrograms, and that dose was not titrated. Levothyroxine initiated again preconception, continued till delivery if there was a pregnancy, whereas the 476 women in the control group were treated with placebo. The primary outcome here was live birth at least 34 weeks gestation. There was no significant difference between groups, and neither were there any differences in rates of pregnancy loss, preterm delivery, or any of the neonatal outcomes they looked at. And finally, we have the newest trial in this space. This one is known as T for Life and was conducted in the Netherlands. Here, women were eligible for inclusion if they were TPO antibody positive and had a history of 2 or more pregnant losses and were euthyroid. They were treated with low-dose levothyroxine versus placebo. This trial wound up being prematurely stopped because they had difficulty enrolling, maybe because the other negative trials had already been published at this point. So although this was underpowered to look at their primary outcome of time to live birth, what you can see is that these curves really overlap and there's no real suggestion of separation. So I think largely we can interpret this probably as another negative trial in this space. So in the 2017 ATA guidelines, we suggested that one could consider low-dose levothyroxine in TPO antibody-positive euthyroid women, particularly if they had a history of miscarriage. But I think in light of all these subsequent negative trials, that this guidance probably does not make sense anymore, and this is not something I'm doing any longer in my own practice. So I conclude by noting that the prevalence of antithyroid antibodies is quite high in pregnant women, and that these antibodies are associated with increased risk for the development of hypothyroidism in pregnancy and the development of postpartum thyroiditis following delivery. That we know from observational studies that antithyroid antibodies, particularly the TPO antibodies, are associated with adverse obstetric outcomes, particularly miscarriage and preterm delivery. The mechanisms for those associations are unclear. However, we really do not have strong evidence that any of the interventions studied confer any benefit. So current recommendations are that if you know that women are antibody positive, it is reasonable to monitor TSH in early pregnancy and to treat if women become hypothyroid. But we would currently recommend against treatment with glucocorticoids or selenium, and I think it probably does not make sense in light of current data to treat these women with levothyroxine. And with that, I'll thank you for your attention. It's a pleasure again to be here. I'd like to now talk about the management of women with positive TSH receptor stimulating antibodies in the pregnancy setting. So I'm going to start a little bit about how we measure these TRAB antibodies, their epidemiology and their natural history across the course of pregnancy and postpartum. And then we'll discuss how we can use these antibody titers for diagnosis in the pregnancy setting. We'll discuss how we manage Graves' disease in the pregnancy setting in the pregnant women, and then how we manage and monitor fetal thyroid dysfunction in women who are persistently TRAB positive in the pregnancy setting. And we'll close with just a little bit about TRAB and neonatal thyroid function. So to start with, we have two different types of TRAB antibody assays. So TRABs are just any antibodies that can interfere with the TSH receptor. Receptor assays will measure TSH inhibitory immunoglobulins, which means basically this is looking at the ability of antibodies to bind to the TSH receptor. This does not distinguish between stimulating and blocking immunoglobulins, although if you're measuring these antibodies in a patient who's hyperthyroid, it's reasonably safe to assume that what you're seeing are antibodies that can stimulate. Bioassays are more specific. So these are going to detect the production of cyclic AMP. And so they're going to look at the activity of sort of post-receptor actions. So they can measure stimulatory antibodies, TSH receptor blocking antibodies, or antibodies that may bind to the receptor but not have an effect on thyroid function. And for both of these types of assays, the third generation immunoassays that we currently have are really good. So the sensitivity and specificity are somewhere between 97 and 99%. Now, the incidence of hyperthyroidism as in women, as demonstrated in this large Danish population study, hyperthyroidism is fairly frequently diagnosed in the first trimester of pregnancy, as you can see here, and then also very frequently diagnosed in the post-pregnancy setting in the first year or so after delivery. In women who have TRAB antibodies, the course over gestation can be variable. In general, as is true for TPO antibodies, TRAB titers tend to decline as gestation progresses. So levels are typically highest in the first trimester and lowest around the time of delivery, and then they often recur in the post-pregnancy setting, which is why we often see new hyperthyroidism in women in the first year after giving birth. But within women who have these TRAB titers in pregnancy, some of them will remain low and not high enough to cause maternal or fetal thyroid function throughout gestation. Many of them will be high in the first trimester and decline, may or may not decline really to what we consider to be normal levels. And in occasional patients, as in the red line here, we see persistent antibody titers really right across gestation, and they don't seem to come down. Those TRABs can cross the placenta to the fetus. The fetus has a thyroid by about week 10 to 12 of gestation. That fetal thyroid is functioning by about week 16 to 20. And once that fetal thyroid starts to function, it can be affected by TRAB. It can also be affected by the maternal anti-thyroid drugs that cross the placenta as well, and by maternal thyroid hormone, which also crosses the placenta. So using TRAB for diagnosis in pregnancy, I've shown you that the first trimester of pregnancy is really a common time for hyperthyroidism to be diagnosed. Outside the setting of pregnancy in women of reproductive age, the most common cause of hyperthyroidism is going to be Graves' disease. But in pregnancy, specifically in the first trimester, the most common cause of hyperthyroidism is this entity we know as gestational transient thyrotoxicosis, or GTT. As the name implies, it is transient. It is really due to HCG, so an exaggeration of the normal thyroidal response to HCG levels. This is more frequent in twin or higher order gestations, may also occur in women who have particularly bioactive HCG or whose TSH receptors are particularly sensitive. And this typically does normalize by about 15 weeks of gestation as HCG levels decline. So the recommendation in women who have GTT is not to treat with anti-thyroid drugs, but to provide supportive care. And many of the women with GTT will also have hyperemesis because nausea in pregnancy is also driven by HCG. So these women may need supportive care with antiemetics, with management of any dehydration. They can get a short course of beta blockers if necessary, if they have severe hyperthyroid symptoms, but most of these women we're going to monitor and the hyperthyroidism will get better on its own. We do, though, really need to distinguish between GTT and Graves' disease when hyperthyroidism occurs for the first time in early pregnancy, because the Graves' disease may need treatment with antithyroid drugs. There are a number of clinical clues that can help us figure this out. Again, it's unlikely for women with GTT not to have nausea and vomiting. Women with Graves' disease are really more likely to have hyperthyroid type symptoms than the GTT patients. The ratio of T3 to T4 is usually higher in Graves' disease. If a patient has eye disease or a diffuse goiter with bruit, you know what you're treating. But often we can't distinguish between these two entities just based on signs and symptoms. And this is where the presence of TRAb can be really helpful because, again, these antibodies are highly sensitive and specific, and then they can, pretty clearly make the diagnosis of Graves' disease when we can't tell on other grounds. So once we've diagnosed Graves' disease in pregnancy, the next thing to do is to assess peripheral thyroid hormone and to distinguish between overt versus subclinical hyperthyroidism. And the reason for that is that subclinical Graves' disease, where the peripheral hormones are normal, even though the TSH is low, is not associated with adverse obstetric outcomes, as we know from this large cohort study from Brian Casey and from other cohorts like it. So subclinical Graves' disease, when the peripheral hormones are not high, we can just monitor with serial thyroid function tests and we don't need to intervene. But overt hyperthyroidism from Graves' disease in pregnancy really does need intervention. Without treatment, there are higher risks for intrauterine growth restrictions, so low birth weight, for severe preeclampsia, for preterm delivery, pregnancy loss, stillbirth. You can see maternal congestive heart failure, and there can be cases of thyroid storm, particularly at the time of delivery. The problem is we do not have an unequivocally antithyroid drug, safe antithyroid drug, in early gestation during the period of organogenesis. We've known for some decades that methimazole is linked to birth defects. We've really known only in the last decade, since the publication of this Danish registry study, that PTU also is associated with birth defects. The birth defects are different for the two drugs. So methimazole is more frequently associated with disorders of the musculoskeletal system, the GI tract, sometimes aplasia cutis. PTU exposure in early pregnancy is associated with abnormal cystic structures of the head and neck or abnormal development of the urogenital tract in a male fetus. The risks associated with methimazole are higher, and the anomalies tend to be more severe. Subsequent to that Danish study, we have a larger Korean registry study published in 2018 with almost 3 million mother-child pairs. This study showed the same pattern of these different types of birth defects with the different antithyroid drugs, but a somewhat lower absolute risk than had been seen in Denmark. So in the Korean registry study, for every 1,000 live births in women treated with antithyroid drugs compared to women without that antithyroid drug exposure, one would expect an additional 9 birth defects with PTU, an additional 17 with methimazole, and additional 16 and a half if women were treated with both PTU and methimazole in early gestation. Unfortunately, their children seem to be at risk for both sets of birth defects. So the older guidance, we recommended treating women with methimazole until they knew they were pregnant and then switching immediately to PTU. That may not be the correct approach, because we would prefer for women really not to have any methimazole exposure in the first trimester if we can avoid it. So this leads to, I think, stronger emphasis on switching women to PTU preconception when pregnancy is planned. This also, in general, shifts a lot of emphasis to the importance of preconception counseling for any patient who is a woman of childbearing age who's diagnosed with Graves' disease. We always want to ask about plans for pregnancy. I think we always want to have a very nuanced discussion and to think about options that will optimize the Graves' disease in the gestational setting. So the advantage of definitive therapy with either radioactive iodine or thyroidectomy is that we don't have to then treat women with antithyroid drug at all in pregnancy. There does need to be a delay though. So after thyroidectomy, you wouldn't want a woman to get pregnant until she's on a normal sort of stable dose of levothyroxine. So that may take a few months. Following radioactive iodine, it's really recommended not to get pregnant for at least 6 months after treatment. And certainly, again, need to make sure that she's on a stable dose of levothyroxine and that thyroid function is optimized. Some women really are not going to want to be, rendered permanently hypothyroid. Some women, if they're older, they may not want to wait months until just conceiving. So this is not one size fits all advice. This is a conversation that really needs to be individualized. A part of that conversation also is thinking about what happens to the TRAb titers after these different therapies. So following initiation of antithyroid drug or following total thyroidectomy, we typically see a continuous decline in those TRAb titers. But following radioactive iodine treatment, the pattern is different. And there will be an increase typically in TRAb titers for about the first year after treatment. By about a year out, they're back at baseline, but after that, although levels will continue to decline, in general, the TRAb titers may stay higher after radioactive iodine treatment than they do with either surgical or medical treatment. When using antithyroid drugs in pregnancy, current guidelines recommend using PTU certainly through the first trimester. Once organogenesis is complete, it's really not clear whether we should switch back from PTU to methimazole or should continue on PTU until delivery. The argument for switching back to methimazole is that we know PTU has been associated with rare but devastating cases of fulminant hepatic failure, and that has been reported in the pregnancy setting. So we would, in general, like to minimize PTU exposure as much as possible. The argument against switching, though, is that, it's not a one-to-one dose conversion. So if you're switching from PTU to methimazole, there's always a risk that you're going to transiently render a woman hypo or hyperthyroid as you make the change. Current ATA guidelines really do not provide any help. They don't tell us which way to go. I think the upcoming guidelines may provide a little bit more guidance. But I will say right now in my own practice, I tend to switch women back to methimazole after the first trimester, if only because it's easier to take a daily dose. In using either antithyroid drug in a woman with Graves' disease in pregnancy, it's really important not to overdose. And the reason for that is that we think the fetal thyroid is actually more sensitive to these medications than the maternal thyroid. So if you treat a pregnant woman until her free T4 is kind of solidly mid-normal, you're probably overtreating the fetus. And that fetal hypothyroidism could have adverse effects on the fetal brain development. So therefore, the target of therapy is the antithyroid dose that is the lowest you can get away with, which is the dose that's going to keep the maternal free T4 levels at, or maybe even just a little bit above the upper limit of normal. And frequent monitoring is important because, again, those TRAb titers may wane and you may need to be adjusting doses as pregnancy progresses. So that's how we manage the mother. How do we diagnose and manage thyroid dysfunction in the fetus once that fetal thyroid is working? We have the capacity to measure this directly. Chordocentesis or umbilical cord blood sampling can be performed under ultrasound guidance, but this is not without risk. There is a 1% risk of fetal death with this, and there are also non-trivial risks for fetal infection, bleeding, fetal bradycardia, and preterm labor. So this is really something we're going to do only as a last resort. And by and large, we're going to look for non-invasive ways of assessing what's happening to the fetal thyroid. One of those modes of assessment is looking at those maternal TRAb titers. So in any woman who has Graves' disease who's on antithyroid drugs, or who has Graves' disease and has a history of either thyroidectomy or radioactive iodine treatment, so she's on levothyroxine, but may still have those TRAb titers around, we need to be testing TRAb to sort of gauge the fetal effects of those TRAb titers. However, in women who have a history of Graves' disease and are in remission and not requiring antithyroid drugs, then we don't need to check the TRAb in pregnancy, because if the TRAb titers are not high enough to cause maternal hyperthyroidism, it's a safe bet that they're not going to be causing hyperthyroidism in the fetus either. So in those women where testing is appropriate, current ATA guidelines recommends initially testing TRAb at the first antenatal visit. If it is normal, which is defined here as less than 3 times the upper limit, then you do not need to repeat the testing as pregnancy progresses, because remember, those titers are largely going to decline as pregnancy progresses. They really don't increase. But if the TRAb is elevated at that first antenatal visit, then the TRAb testing should be repeated around week 18 to 22, which is when that fetal thyroid starts to become susceptible. And if titers are high, again, 3 times upper limit of normal or higher, alert maternal fetal medicine for close monitoring, and repeat again at 30 to 34 weeks to gauge the likelihood of neonatal hyperthyroidism and to potentially alert our pediatric colleagues. The other important clue to fetal thyroid function is fetal ultrasound. So here we need to work very closely with our obstetric colleagues in these patients. And they can do fetal thyroid and look for goiter, which you can see pictured here. You can see fetal goiter in either fetal hypothyroidism from those anti-thyroid drugs or from fetal hyperthyroidism from the TRAb that's crossing the placenta. There are other clues as to which direction the shift is. So bone maturation that's either delayed or advanced can give you a clue. And fetal tachycardia, which would be a sustained fetal heart rate that's at least 160 beats per minute, again, can be a clue to fetal hyperthyroidism. It's really important not to forget patients who look like this. So you can see from her scar that she had a thyroidectomy. You can see from her eyes that that was done for Graves' disease. And this is her infant who was born with neonatal Graves. So it's really important to keep track of why our patients are hypothyroid. And with patients with a history of Graves' disease, important to keep that kind of front and center in the chart so we don't forget about it. In women who have an intact thyroid, again, the fetus can be affected by the TSH stimulating antibodies in Graves' disease and also by the anti-thyroid drug, and the balance of what's crossing the placenta may be different from patient to patient, which is why we have to monitor the fetus closely. But in women who are athyrotic, who've had radioactive iodine treatment or thyroidectomy, they're getting their thyroid hormone as levothyroxine. Here, the fetus is not going to be seeing anti-thyroid drugs necessarily. They're just going to be seeing those stimulating or potentially blocking antibodies. And so those fetuses may be at particularly high risk for fetal hyperthyroidism. In women who have radioactive iodine, timing of that radioactive iodine preconception matters. Again, guidelines really recommend against treatment or conception within 6 months after treatment because there's a higher rate of fetal anomalies. But longer waiting period after radioactive iodine may be beneficial in terms of TRAb titers coming down. So these are data from Japan published in 2019, showing that among newborns of women with Graves' disease who conceived within 6 to 12 months after radioactive iodine treatment, the likelihood of neonatal hyperthyroidism was about 8.8%, but it declined to about 3.6% in women who conceived at least 18 months after that radioactive iodine treatment. So again, that waiting period may be beneficial for fetal health. What do we do when we have a mother and a fetus who may have discordant thyroid status? These cases are very unusual, but this is partly why we're monitoring to pick them up. So fetal hyperthyroidism in a hypothyroid mother with a history of Graves, again, this is going to be a mother who's athyrotic from thyroid surgery or who's had radioactive iodine. Here, we can treat the mother with methimazole if necessary, if there seems to be fetal hyperthyroidism based on ultrasonography or based on, if you have to, cortocentesis after the first trimester, really starting mid-gestation, with frequent adjustment of doses based really on the goiter size. You want to start seeing that come down and based on fetal tachycardia. We want to use the lowest dose necessary to normalize the fetal heart rate to keep it in the range of 110 to 160 beats per minute. And again, we really want to try to avoid overdosing because fetal hypothyroidism may adversely affect fetal brain development. So these are women where we need to monitor very closely with fetal assessment every 1 to 2 weeks. Again, looking at fetal growth, fetal goiter, amniotic fluid index. And an important note is that these are the only patients who should be getting so-called block replace treatment in pregnancy. In a woman with an intact thyroid who has hyperthyroidism and need anti-thyroid drugs, we should not be treating as well with levothyroxine. That is not a good strategy in the pregnant patient because the anti-thyroid drugs are going to cross the placenta at a much higher level than the levothyroxine, and that's incurs huge risk for the fetus to be hypothyroid. So again, this strategy of both levothyroxine and antithyroid drug would only be in a pregnant woman who doesn't have a functional thyroid herself. The antithyroid drug is strictly to treat the fetal thyroid gland. Now, how about the other potential possibility where they're discordant? So the fetus is hypothyroid, but the pregnant patient has active Graves' disease and hyperthyroidism. So this is uncommon, but this would effectively reflect a fetus who is seeing a greater balance of antithyroid drug crossing the placenta compared to the TRAB titers. And the first thing to do if you suspect fetal hypothyroidism in this scenario is to decrease the antithyroid drug dose. But in rare cases where there's sort of massive fetal goiter that needs to be addressed, there are case reports of successfully using intraamniotic levothyroxine injections. Again, this is not without risk, so this is kind of a treatment of last resort. But if you inject the levothyroxine into the amniotic fluid, the fetus is going to swallow that fluid. So basically get its own levothyroxine dose separate from what the mother is seeing. And again, if pursuing this strategy, one would want to be monitoring fetal ultrasound for the best possible clues as to the fetal thyroid function, effectively, mostly for seeing that thyroid goiter decrease in size. So finally, what happens in the neonatal setting to infants who are born with mothers who have TRAB antibodies? There are a few things that can happen in the neonate. So one is neonatal Graves' disease from the transplacental passage of those TRAB antibodies causing fetal hyperthyroidism in most cases, although rarely if you have binding or inhibitory antibodies, you can see the result is fetal hypothyroidism. And really in an athyrotic female, who's pregnant, I think the only time when you really strictly should only be using those antibody titers that are looking at action that can discriminate between binding and antibodies that inhibit and stimulate the thyroid is in this scenario where you want to see what is happening potentially in the fetal thyroid. You can see hypothyroidism in a newborn born to a mother with Graves' disease due to passage of those inhibitory antibodies, or more frequently due to the transplacental passage of antithyroid drug. And then sometimes these children can get central hypothyroidism that's either transient or permanent because very high levels of maternal thyroid hormone may cause suppression of the hypothalamic pituitary thyroid axis. That's something typically you're going to only see in women who are really uncontrolled with Graves' disease in the pregnancy setting. So neonatal Graves' disease overall occurs in about 1 to 5% of children of mothers with Graves. Important to remember that the half-life of maternal TRAB in infant circulation is about 2 weeks, so it's not cleared for about 4 to 6 months. But in mothers who'd been on antithyroid drug until delivery, the hyperthyroidism in the infant may not manifest until those antithyroid drugs are cleared from the neonatal circulation, which takes about 2 to 5 days. And then again, following disappearance of the maternal TRAB, there could be a phase of neonatal central hypothyroidism due to prolonged suppression of the axis. And so one needs to follow these infants out very closely. Neonatal Graves can look like this. This is kind of a classic image from the New England Journal. These infants can have tachycardia, hyperexcitability, goiter, poor weight gain, advanced bone age, eye signs, hepatomegaly or splenomegaly. And these are children at increased risk for cardiac insufficiency, for death, for growth retardation, premature delivery, microcephaly, psychomotor disabilities. So we want to prevent this when we can. So I would conclude that TRAB these days are really good assays. They're sensitive and specific for Graves' disease in and out of the pregnancy setting. In women with these antibodies, preconception counseling is critical, and that when treating Graves' disease in pregnancy, we need to use the lowest possible dose of antithyroid drugs and monitor frequently. We can use both TRAB and ultrasound to assess the risk for fetal and neonatal Graves' disease, and we need to follow these patients closely. And with that, I'll thank you for your attention.
Thank you very much, Dr. for this information. In nursing women.
Good evening, ladies and gentlemen. In the beginning, I would like to thank the organizing committee for giving me the opportunity to talk to you today. My name is Dr. Bashir Taha Saleh. I am an Emeritus Chair of Obstetric Medicine in Corniche Hospital, Abu Dhabi. Well, I'm going to talk to you about in 15 minutes, 20 minutes or so, about postpartum care of patients with thyroid dysfunction in nursing women. I have no actual or potential conflict of interest in relation to this presentation. My objective will be the definition, the epidemiology of postpartum thyroid dysfunction, the clinical presentation, the treatment, end up with conclusion. The occurrence of thyroid dysfunction, excluding Graves' disease, in the first postpartum year in women who were euthyroid prior to pregnancy. It is an inflammatory autoimmune condition in the classic form. Transit thyrotoxicosis is followed by transit hypothyroidism with a return to the euthyroid state by the end of the initial postpartum year. The clinical course of postpartum varies, with approximately 1/4 of patients presenting with the classical form, 1/4 with isolated thyrotoxicosis, and 1/2 presenting with isolated hypothyroidism. The postpartum period is characterized by rebound from immune tolerance induced during pregnancy. This inflammatory autoimmune condition occurs mostly in women who are thyroid antibody positive in early pregnancy. And that's what gives us the clue to check thyroid antibodies in early pregnancy. The postpartum thyroid dysfunction is a common condition. It affects about 5 to 10% of women. Higher prevalence in type 1 diabetes, up to 25%. And prior postpartum thyroiditis, up to 42%. It can have a significant impact on mother's health and her ability to breastfeed. Can present in one of the three ways: a transit hyperthyroidism alone, a transit hypothyroidism alone, or the transit hyperthyroidism followed by hypothyroidism and then recover. What is the typical sequence? The thyrotoxicosis period from 4 to 8 weeks caused by leakage of performed hormone from the thyroid gland into the bloodstream. Thyrotoxic phase only seen in 50% of women. But transit hypothyroidism from 4 to 6 months, and it accounts for 25% hypothyroidism. Most women will become euthyroid again within a year, but up to 50% will develop chronic hypothyroidism after initial recovery. Postpartum thyroiditis recurs in about 70% of subsequent pregnancies. This is a graphic form illustrate whatever I've been seeing now. It is a postpartum thyroiditis subtype. It is a destructive thyroiditis in 50%, that is a blue line. Biphasic destructive thyroiditis in 20%, this is the brown line. And transient hypothyroidism with a green line, which you see, it is going below the graph. And permanent hypothyroidism in only 5%. So the treatment of hypothyroidism is beta blocker if symptomatic, no indication for antithyroid drugs. As you know, antithyroid drugs is meant mainly for synthesis of thyroid hormone, whereby this condition is more of a release rather than synthesis. Levothyroxine is, as you know, is a drug of choice for management hypothyroidism. What is a postpartum thyroiditis? It's the most common cause of postpartum thyrotoxicosis. Prevalence is about 5%, almost 40 to 50% of women with antithyroid peroxidase antibodies in early pregnancy will develop postpartum thyroiditis. It is important to look for a differential diagnosis because it can be a true Graves' disease. It is a high-risk population where you have to set the test for postpartum thyroiditis. That is, as we mentioned, type 1 diabetes, history of postpartum thyroiditis, but again, Graves' disease, chronic hepatitis C, autoimmune disease, non-thyroidal, and TPO antibodies, and Hashimoto's thyroiditis is among the risk group. What are the symptoms or signs? Hyperthyroidism is typically mild. It's fatigue, weight loss, palpitation, heat intolerance, anxiety, irritability, tachycardia, and tremor, whereby hypothyroidism is usually mild. Lack of energy, cold intolerance, constipation, sluggishness, and dry skin. Symptoms of postpartum thyroiditis are usually attributed to breastfeeding or the stress of having a newborn, lack of sleep, and normal the postpartum period. The thyroid gland is mildly enlarged, diffuse, but not tender. And the lab findings in the hypothyroid phase, high or high normal serum free T4 and T3 concentration, and low serum TSH. The hypothyroid phase, serum T4 is low or low normal, and the serum TSH is usually high. What do we find if we do thyroid biopsies? Lymphocytic infiltration with occasional germinal centers and disruption and collapse of thyroid follicles. Fine needle aspiration biopsies, lymphocytes, thyroid follicle cells, and masses of colloid. During the recovery, lymphocytic infiltration is seen, and there may be some fibrosis, but the thyroid follicles are more normal. There is insufficient evidence to support a recommendation for screening all pregnant people for postpartum thyroiditis. And there is not a definite strong association between postpartum depression and difficulty of lactating and hypothyroidism. But it is recommended that a serum TSH should also be checked in the setting of this condition, i.e. postpartum depression or difficulty in lactating. If patients have thyrotoxicosis, new onset or recurrent Graves' disease must be differentiated from postpartum thyroiditis because the management differs. In Graves' disease, as you know, TSH receptor antibodies are positive. In postpartum thyroiditis, TRAb is positive. Antibodies should be positive if mixed type disease is seen. The physical stigmata of Graves' disease, such as diffuse goiter with a prurine or ophthalmopathy, are diagnostic when they are present. An elevated T4-to-3 ratio is more of postpartum thyroiditis. Radioiodine uptake is elevated or normal in Graves' disease, but the radioiodine uptake is slow in the thyrotoxis of postpartum thyroiditis. This is a typical signs of myxedema, exophthalmos, and toxic multinuclear goiter, which you see in Graves' disease. What is the treatment? In postpartum thyroiditis is supportive. Monitoring of thyroid function, treat if there is hypothyroidism. If Graves' disease, medication as usual with beta blocker antithyroid drugs. And radioactive iodine is sometimes contraindicated if it is in pregnancy or in the lactating period. Transit hyperthyroidism of pregnancy requires usually no treatment, is resolved on its own. The management following the resolution of the cytotoxic phase, TSH should be measured in 4 to 8 weeks, or if new symptoms develop, to screen for the hypothyroid phase. This is a strong recommendation with high quality evidence. Thyroxine treatment should be considered during the hypothyroid phase of postpartum thyroiditis. If the patient is symptomatic due to postpartum thyroiditis, or recommended if the patient is considering another conception. If the treatment is not initiated, the TSH level should be checked in about 4 to 8 weeks until thyroid function normalizes. Thyroxine should also be started in hypothyroid women who are attempting pregnancy or who are breastfeeding. Thyroxine is initiated for postpartum thyroiditis. Discontinuation of the therapy should be attempted after 12 months. Tapering of thyroxine should be avoided when a woman is actively attempting pregnancy or is pregnant. 10 to 50% of women whom the hypothyroid phase of postpartum thyroiditis initially resolve will ultimately go on to develop permanent hypothyroidism. Factors associated with an increased risk of developing permanent hypothyroidism are multiparity, thyroid hypoegonicity in ultrasound, greater severity of the initial hypothyroidism, higher TPO antibodies titers, advanced material age, and history of pregnancy loss, and history or family history of hypothyroidism. Women with prior history of postpartum thyroiditis should have TSH testing annually to evaluate for the development of permanent hypothyroidism. Antithyroid medication and breastfeeding, low to moderate dose of antithyroid drugs like 450 of propyluracil, PTU, or 20 milligram of metimazole and carbimazole can be safely used in lactating women. And that is a message to my obstetric colleagues in Cornish Hospital. But radiopharmaceutical scanning is avoided during lactation. Iodide 131 is incompatible with breastfeeding, and the iodide concentrates not only in the maternal thyroid gland, but also in the breast tissue and breast milk. In conclusion, ladies and gentlemen, breastfeeding can continue in mothers with postpartum thyroid dysfunction while receiving appropriate treatment. Early diagnosis and management of postpartum thyroid dysfunction can help improve outcomes for both the mother and the baby. Postpartum thyroid dysfunction is a common condition with significant impact on mother's health and ability to breastfeed. Annual TSH tests for 5 to 10 years are recommended for women with history of postpartum thyroiditis. They have an increased risk of developing permanent overt hypothyroidism. And I'll finish off with two questions, which I think you know the answers. Does maternal thyroid hormone status impact lactation? I think you have seen that the answer is yes. Both hypothyroidism and hyperthyroidism should be treated during lactation. There is limited data, but the recommendation is to treat especially hypothyroidism. There is insufficient evidence for hypothyroidism, but symptomatic treatment might be indicated. Are antithyroid drugs, PTU or metamidazole or carbimazole, transferred to breast milk, and what are the clinical consequences of breast infant? Low to moderate doses of post-PTU, 450 milligram, and metamidazole or carbimazole, 20 milligrams, are safe. The amount of disease drugs secreted in the breast milk, especially PTU, is very minimal and does no harm for the infant. We would like to see this happy mother and happy baby in our lactating mother. Thank you very much for listening. These are my references, and thank you.
Many thanks, Dr. Bashir, for this elegant talk. We have one question for you about the use of propyluracil. We know that it's safe in the first trimester of the pregnancy, but in some countries there is a deficiency sometimes for propyluracil. What should we do in this condition? Should give the patient carbimazole or mesimazole with its side effect, and which dose can we give?
Good afternoon. Thank you very much for having me now as a panelist. Yeah, the answer is really given by Professor Elizabeth Pires. And I think the change of PTU to metamidazole or vice versa from metamidazole or PTU is not really recommended by most of the organizations. And the PTU, although it is has less congenital anomalies, so that's why we use it in the first trimester. And because of latest reports of liver failure and liver toxicity, that's why we stop it in the second trimester and go back to metronidazole. But I think the shifting from one drug to another is accompanied by many side effects, and we try to avoid it as much as possible. But the dose, as I mentioned, of 20 milligram carbamazole or 450 milligram of PTU is safe in a lactating mother and cause no harm for the baby.
Okay, as regard to the lactation, should we separate the time of administration of this drug after the mother lactating the baby? How many hours?
Well, if a lactating mother can really have a gap between getting the dose and the second dose, that would be nice, really, because then you minimize the effect of these drugs in the babies. But if the mother is not taking a high dose, more than the one I just mentioned, I think there is no harm to space the time between lactating and the ingestion of the drug.
Dr. Salwa?
Okay, thank you again, Dr. Bashir. And there is it Dr. Pierce with us, or we can ask Dr. Bashir?
No, she
Okay.
joined.
So it's about, again, the antithyroid medication in pregnancy, in the early pregnancy. Is it just because both of them, the methimazole as well as the PTU, because congenital anomaly? Is it possible just to avoid them in just the organogenesis period between 6 and 10 weeks? And that would do in spite of the Graves' disease or the hyperthyroidism?
Yes, Dr. Selva, that is an excellent question. And I wish Professor Elizabeth was here with us because there are, I think I heard Dr. Tim Corvetter from Netherlands, where he says that if a patient is on BTU, has hyperthyroidism, BTU, it is really advisable to stop the drug in early pregnancy, where we have the threat of organogenesis, because the relapse for hyperthyroidism or thyrotoxicosis takes about 4 to 6 and maybe longer than that. So there is a good window to stop the antithyroid medication in early pregnancy and avoid the organogenesis and then start it, because the relapse will take some few weeks, and we will use this window not to give the woman any drug.
That's great. So let's see any other questions.
We should monitoring baby for side effect of antithyroid drugs for the mother for every how many months, as regard the describing of lactating mother for antithyroid drugs. We should monitoring the fetus or of the baby of lactating mother receiving antithyroid drug.
Yeah, if she is in a high dose, yes, because I think the first few days your neonatologist should check really the babies, because that is a time everything is passed through the placenta in the newborn. But and if the baby doesn't show any signs of hyperthyroidism, then there is no need really. But if the mother is continuing on antithyroid drugs, I think checking the baby's thyroid function is advisable, especially if it is in a high dose or she had a relapse after delivery.
Yeah. Again, there is a question. In fact, it's about a topic that was mentioned by Dr. Pierce, but I hope Dr. Bashir may give us an idea about that. It's about the TRAP, which is thyrotoxic TSH antibodies. She mentioned that this TRAP, it would decrease after the antithyroid medication to mainly down, but after the radioactive iodine, it would take time. It would take time to be reduced to the minimum value. And we know that the TRAP by itself, it is related to the relapse rate. So if it is high, the relapse rate of the after the antithyroid is high. So why is that? And we know that the radioactive iodine ablation, this is a definitive treatment, but if we see the antibodies, maybe in 6 months, still it is high. So no, I don't know what is the explanation of this.
Well, if I understood what Professor Pierce has said, yeah, you have really to give a break after the radioiodine treatment, because really the antibodies, so they come down, but they have a surge after that. And that's why we should wait before giving advice to these women to get pregnant. So this surge is not recommended, and you have seen that positivity of anti-TRAP is associated with bad obstetric outcomes. So whether it is preterm or miscarriage and so on. So the advice is really not to get pregnant between 6 and 1 year after radioimmunoassay treatment.
Okay. So, Dr. Agada, do you have other questions from your side?
No. Break.
Okay. So with that, we thank both speakers for their excellent talks, and we'll move on to the next session. Thank you all for attending.